All right, well, good morning, everyone, and welcome to the second live coronary case. This is going to be a live case from the Case Western Hospital in Cleveland with Dr. Hiram Bezerra. But before we start, let me introduce our panel. Dr. Stéphane Rinfret from McGill in Canada is going to be moderating the case. And we have a wonderful panel of experienced complex operators: Mauricio Cohen, Wissam Jaber, Jay Khatri, Mitul Patel, Timir Paul, Tony Speedy, Katalin Toma, and Poonam Velakepuri. So without further ado, I will pass it over to Stéphane, who is organizing the MLCTO, one of the best meetings of CTO in the world. And Stéphane, take it over.
Good morning, Dr. Bezerra.
Good morning. Good morning, Denver.
Hello, hello. So we're pleased to join you, and we have a very great panel ready to listen to your plan of this of today's case. I have the privilege to co-chair this session with Manos Brilakis.
Hello, Hiram. Good morning.
We have Poonam Velakepuri. We have Katalin Toma. We have
Tony Speedy.
Tony Speedy. I'm just getting far from the names.
Say the names to make it easier. Timir Paul, Jay Khatri, Sadi Alres, Wissam Jaber, and Mauricio Cohen.
There you go.
So have an amazing panel, lots of
amazing panel, great moderators.
So walk us.
Stéphane, Manos, thank you first for the opportunity. Obviously, thank you to Suba and to my Cleveland fellow, Maddie Shishibor. It's a great privilege to be part of this fantastic course. Just a quick intro on the room here. We have Dr. Najib Osman in my right here. Then Shinidu Igor, who is our second-year advanced fellow. In the room, we have Maria, Phil, and Nick, and on the keyboard, Casey. So a team here for us. Everything gotta go right. Shinidu is gonna introduce the case briefly here.
Next. Okay, our patient, she's a 49-year-old woman with a history of end-stage renal disease who had a first diagnostic CAT for cardiac risk stratification prior to renal transplant. She also complains of shortness of breath with moderate exertion and some very mild angina as well. History other than end-stage renal, she's got a history of anemia, breast cancer, hyperparathyroidism, and multiple DVTs. On Coumadin, amlodipine, hydralazine, losartan, aspirin. Next. Vitals are stable, except for, very stable. Physical exam also pretty much unremarkable. Next. Labs as well, pretty much unremarkable except for her creatinine of 7.4, and as we said, she's on dialysis. Her echo, essentially EF is normal and had no significant wall motion abnormality. Next. Her EKG, normal sinus rhythm, narrow QRS, and you can see Q waves in the V1, V2, and no other evidence of a prior infarction. Next. So on the left, you see her ventriculogram. EF is essentially normal. You can see her right coronary artery's got mild proximal to mid disease. Next. So her left main is normal. Pretty calcified vessels. Her circumflex artery is also essentially normal. You can see in this caudal view that you have a mid-LED lesion, which we'll further appreciate in the cranial view. Next. So here you can see pretty much 99% heavily calcified mid-LED lesion. And you can see a diag that's 100% occluded. Next. You can better appreciate that in this cranial view as well. Next. Okay.
All right, folks. It's obviously kind of a typical renal case with a lot of calcium. I think that's the main interest of this case. I don't know if the panel would call this a CTO or not. Why don't we start there? Are we dealing with
But we think, I mean, I'd like to hear what the panel says, but there's clearly a diagonal CTO without any doubt on this, which is of a fair, which fills a fair territory, and a subtotal lesion that cannot be called a CTO because you've got TIMI2 flow. So I'd like to hear the panel. When you see coronaries like that before injecting, where you actually can see the whole coronary tree, is it driving anything different in terms of your assessment? Are you going to start shooting the right? Are you going to start shooting the left? Are you planning differently your strategy? Are you looking more? Are you going to be more sensitive to maybe do functional testing if you find moderate lesions? Is it changing your strategy overall? Tony.
Yes. So to me, the lesion looks, angiographically very significant. I agree. I think the LED is just subtotaled and has slightly diminished flow, and the diagonal looks chronically occluded. I guess you're right away, almost for sure, thinking atherectomy on a case like this with severe calcification. It's pretty extensive. And the other decision you have to make, for me at least, would be, are you going to mess with the diagonal, or are you just going to do the LED? It'll change the case quite a bit on complexity. I'd be tempted to just do the LED and not worry too much about the diagonal.
Let's have a show of hands for our guest operator. Who would be basically targeting the LED for as a first step and maybe stage the CTO, and who would as a first choice, and who would be definitely planning to do the CTO as a second step with or without ischemia as part of a complete revascularization? Who would say do the LED, wait for ischemia, inducible ischemia symptoms, and do it afterward? That's choice A. And B, planning to do the CTO right away. So A. And B. Nobody. So everybody is in favor of treating the LED and maybe reassess afterward how your patient is doing. And I guess it's what your guys are planning today.
Stefan, I have a question here. So
just to add for the discussion, just to clarify, she didn't do measurements. So what triggered this diagnostic CAT to start with is a pre-op of a transplant, right? I mean, her symptoms are minimal. Just for your consideration on the strategy here.
Is it going to change, in your center, is it going to change the likelihood that the patient can be grafted on dual antiplatelet therapy? Would they graft a kidney on dual antiplatelet therapy, or they will want to wait for the dual antiplatelet therapy to be stopped?
Very good point, Stefan. So our group here, they are okay with Plavix. They are not okay with new agents, more potent, but they are okay proceeding with transplant on Plavix and aspirin. In the past, we did offer short-term DAPT so they can be listed faster, because the worst thing is to stand these patients and then wait and end up on the wrist and nose window, right? So we want to list them right away, and if they are on Plavix, our surgeons are okay with that.
Mauricio has a question, and then we'll go back to your plan on how you want to treat that today. Mauricio?
Yeah, so this is more of a clinical question, and this is probably what people are wondering here. So why do you need to revascularize somebody who's minimally symptomatic, as you said, has a mid-LAD lesion that is severe and has good LV function before surgery. This is not, the usual clinical thinking. Maybe you may want to revascularize it because otherwise she would not get a renal transplant, but that's a different reason.
Right. Yeah, the short answer is what you mentioned last. They will not take her, they will not list her for transplant. Independent on that, I think our criteria here has been driven mostly by anatomy and myocardial at risk. I think this lady, any kind of surgical endeavor, she's going to end up with probably a sizable type 2 MI. It's not symmetry flow on the LAD. So independent on the transplant opinion, I would feel strongly of opening this LAD before any other non-cardiac intervention.
I think you're making a very good point, especially that the fact that she, it's nothing to be, this LED flow will nothing but get worse if anything happens. If she ends up with a preoperative MI, that might impact her overall prognosis after the transplant. And I don't think we have a lot of data from the literature in that specific population to actually state that it would not be good practice to do a revascularization. And to be honest, all anesthesiologists in the world and transplant team and in our center for sure would advise us to fix that lesion before to proceed. So I think it's very reasonable. And please tell us what's your plan today on how to manage this LAD.
So I would love for us to decide lesion prep based on intravascular imaging. Before I tell you what we did so far, I'd like to hear from the panel and maybe from the audience. How many from the get-go voting for atherectomy here?
Could you put the LAD and areocranial again for us?
Let me give you today's picture because it's probably better. So does it help?
It does. It does. So I'd like to hear the panel. We've got nowadays beyond beyond rotablation, we've got orbital atherectomy. Some might consider just going with a balloon in this lesion and see how it goes. And we will obviously in the near future, and it's available in Europe, shockwave as an option. We know that imaging can have a big impact on the selection of the modality in order to prepare that lesion. So I'd like to hear what the panel think about how should we prepare that lesion, and should it be prepared first, and if so, how should we be doing it?
So can I, so for this lesion, normally I would, of course, wire and then try to image it first. Sometimes I've been fooled, it's a thrombus, and you think it's calcium, you think it's thrombus. So definitely I would wire and see if my imaging equipment would pass. It looks unlikely that it would. They would try a small balloon and then go from there, see how much calcium. But this looks more like a upfront atherectomy.
Because you're saying crossing, is it important to choose the choice of a wire here? We have an extremely complex anatomy where basically you see that there's forward flow through that lesion, but to understand where the channel is, it's likely on the right of the screen where there's a beak of the lesion right there. And maybe the choice of the wire can make a huge difference. And personally, I would stay away from any polymer jacket in that lesion because the only thing you can do is just get subintimal and then lose the flow in your LED. I would basically select a more modern technology in terms of hydrophilic but not polymer coated. But I'd like to hear what the panel, Tony, you're doing CTOs, what would be your first approach on this lesion?
Yeah, I think just for safety, it's a short lesion, I'd still try typically a spring-coiled wire first. And I agree, because I'd worry if you tried something else, you might drive it subintimal, but maybe after that go with a tapered or another wire. But
What about Sion, Samurai RC, and that type of of hydrophilic non-coated wire might be a good choice, right?
exactly.
And I think another important point here is, and I got burned with situations like this. This doesn't look, it's not a CTO, but it can become something that we treat like a CTO very quickly. So you have to be ready to do something about it if you end up subintimal here, which can certainly happen. So you need to be able to do a stingray reentry. You have to think about all this stuff before, think 2 steps ahead of the curve. I mean, it may be something that takes 2 seconds to wire, but it may be something that ends up subintimal.
So Catalin is pointing to the fact that sometimes lesions that are critical may be worse in terms of wiring than even CTO lesions because you don't have collaterals. So you can't miss your target with the choice of your wires and how you will do it. And the use of microcatheters and the use of dedicated wire may be very important in that case. And what's your plan so far, and what do you want to do in terms of imaging, if so? And obviously, I can't imagine any imaging tool that could cross that lesion and give you any answer before doing anything first. So let me know.
Yeah, so I wouldn't expect anything else than what this expert panel cover. I agree with all the points. So my first strategy would be to go with a non-polymer jack wire, as you mentioned, Stefan. Some good hydrophilic, but no polymer jack. Either Xion or run through, they tend to navigate relatively well on calcium. And then I was hoping that if we cross with this kind of workhorse wire, to put a small balloon there, and then be able to image and decide, even for an education standpoint, intravascular imaging criteria for atherectomy. I try run through, it doesn't go. So then we put a Caravel microcatheter, and we end up crossing with a taper wire. Let me see here. So that's, as you said, this is the Caravel right on the right side of the screen, where there is a little, looks like a little channel there.
Yep.
That's as far as it can go with the workhorse wire. And this was very carefully followed by taper wire, with the risk of going subintimal. You're going to see that at some point the wire want to almost knuckle a little bit, cannot be forceful back, and at that point, you see, so try to renegotiate this, and then finally it goes through. So we had the XTA there, and it was very difficult to get the Caravel down. So then I try 1-2 balloon, doesn't come even close, and then a new Caravel was far enough. I think we have an injection here, and it's grabbing on the calcium, but far enough for us to be able to exchange at this point by a floppy wire.
So at this point, you sort of already stratified this lesion as being a very resistant lesion, for which the likelihood to be able to overcome, its resistance is very low with anything else than Rhoda or somewhere else.
Yeah, because I think before, I think the role of intravascular imaging would be more towards fine stent expansion. But at this point here, it's a bailout situation. I mean, we cannot cross with a very small profile balloon, right? So I don't think we have an option other than atherectomy here.
So you might be, I don't know if you've retrieved your Caravel at this point, but you might be you might want to just look carefully at the nose of the caravelle versus at the nose cone. There's some radiolucency that you can see, which is a predictor of potential detachment of the tip out of the caravelle. So when you see this, we got to be extremely careful of not to rotate the caravelle and be very, and you know, in my experience, although it's a very small profile microcatheter, I've left little souvenirs in coronary with caravelle
Stefano,
that I
was gonna add that
regretted a lot.
I've left these in septals frequently. This is the perfect setup to lose the tip of the caravelle. And I was curious as to why that was chosen again as the second microcatheter, because it breaks.
It breaks. It's a weak. I mean, it's a fantastic moldable microcatheter to get into epicardial collateral. But when you get this caravelle close to calcium, to me, is potential for issues. But fortunately, have you pulled your caravelle so far?
The caravelle is intact.
Perfect.
As you mentioned, I mean, we just cannot spin it.
Sure.
But this is also true. I mean, even with much stronger catheters, like Turnpike, I left some souvenirs also there.
Yeah.
When the nose is attached to the calcium and you are spinning, the nose is detached.
You're right.
I think here is just forward advance with some wire backup, and if it doesn't go, rethink your strategy. For J point, why to choose this one is that it's a very short segment, so I don't necessarily need to cross the entirety of the lesion. I just need enough room to be able to finish the wiring with the Rota floppy. So I'm not fully on that CTO mode that I want the entirety of the microcatheter through it.
So Hiram, you've selected already rotablation. Maybe we can ask Chadi. Chadi, would you do orbital? Or I guess it's already selected, but any thoughts versus orbital versus rotational here?
I mean, there's some sort of tortuosity there, so probably orbital would be favorable, but again, it's not severe enough. So CSI, I think, can do the job, but probably proximal to that CTO, there is also some calcification, probably 50, 60 range. Probably IVUS would be helpful just to see how calcified it is, and do atherectomy all the way, probably 2 to 3 centimeter proximal to CTO.
So Shadi, what do you mention about tortuosity again?
You can do either way. I think CSI can do the tortuosity is not severe. So if you have CSI, will do. Otherwise, Rotas can do the job.
No, but you favor one versus the other. I didn't get it.
CSI.
Is this a consensus on the panel?
Maybe we can go around. I mean, Wissam, what are your thoughts?
No, I think either would work. It's whatever you're comfortable with, whatever your cath lab is comfortable with.
I'm just used to rotablator, so I would probably start with the 1.5 burr.
Yeah, any thoughts about, any thoughts about going with 1.5 versus 125? I have my strong opinion about that.
Yeah, the 125 can get stuck. And in these type of lesions, this is where you get stuck, so you have to be very, very careful. It's happened to me. I was lucky enough that I could yank it out. But the 125 is the one that tends to get stuck more often.
So Mauricio is making a very good point. So for those who are think that it's always safer to go with a smaller burr, the answer is not. The 125 burr is a sort of a rice shape or bullet shape versus the football shape of a 1.5 makes it less likely to get entrapped. And also the technique will have a huge impact on how you may or may not trap the burr. And obviously we will see this in a few minutes, I assume. So you're, get us through how you're equipped right now. Is it 6, 7, 8 French?
So it's 6 French. I was initially planning actually 175 bore, more against towards the stent expansion mindset. But since we proved that it's such a difficult lesion with probably a microchannel through the calcium here, we're going to go with the 1.5. Just one observation with, again, I mean, on the choice of atherectomy, I think most of the case they do, they potentially overlap one way or the other, but One is a kind of a no-cross situation like we have here. I definitely favor hot ablator because of the diamonds right at the tip versus the CSI that is not ablating right at the tip. So you can run in a situation of no cross easily here with a CSI.
You know, the other issue to point out there is that an orbital atherectomy device, if it's hung up and stuck, the orbit continues to get larger and larger where it's stalled, which could potentially increase the likelihood of a complication, whereas the orbit doesn't change on a rotablator, so you can take the time to work at that area.
And also, you may ablate just proximal to your plaque, actually, because it just gets bigger and bigger and never engages into the into where you want to do it. So I sort of share the overwhelming opinion of the panel that the rotablator is the best approach here. And
one question actually maybe for Timir can comment on this. So I see your femoral 6 French. Like personally, I would probably go 8 French. Timir, what are your thoughts? Would you go big here or would you go smaller?
I'll go with the bigger one, bigger French sheet.
I just thought that would be an insult to Stefan. We already going femoral 8 French.
To be honest, I'll tell you exactly what I would have done in that case with all the calcium. You know, if I'm sticking a femoral, and I would have likely stuck a femoral, I would have used an 8. I don't think there's a big...
You would have done femoral this case, Stefan?
If I would have used a radial...
No, I want to hear. Would you?
Oh, yeah. So if...
Thank you.
No. If I had used a radial, I would have used a 6/7 slender and put a 7 French in. If I'd used a femoral, because of all the calcium and everything, to keep all the options open to me and burr up to 2.0, I would have used an 8. Yeah. We are not, it's not a dogmatic world. I've learned a lot from my femoral. Like, I think what I've brought in that field over the last 10 years is I brought more radial, but they made me better at doing femoral as well, and getting out of some of the dogmas of being a radial Qaeda. So
I'm obviously just provoking. Is that I respect immensely how far you brought radial in terms of complexity, and I think here either way, I almost went 8. At that level of the LAD, since it's past the diagonal, I think it's more ectatic than true vessel. So I wasn't expecting us to need a 2.0 bore. So that's why I end up going with 6 French. But I don't think there is a big...
You know, I'm curious about this discussion about the burr size. I would think that if you can bore out a channel with a 125 or a 15, anything that's left you could fix with a cutting balloon. Why are we even talking about larger burrs? I honestly never use them.
I don't agree with that. I think depending on the calcium, as much as you do intravascular image, you're going to see that there are situations that you actually want the bulk more. So it's not to get your stent down. I mean, anything can get your stent down. But really,
no, I couldn't agree with you more, but most of the time with imaging, what I see is that the arc of calcium is cracked with a cutting balloon, and that's generally what we're trying to achieve anyways.
Yeah.
I think
I don't think the scoring balloons do much for us.
The other issue here is the thickness of the calcium, and I think this is what Hiram is going to get to later on. And I think this would be an argument to use a larger burr. So you score the plaque with a smaller burr, which may allow you to get in and maybe allow you to crack the plaque. But if the calcium is really thick, you're going to have trouble expanding there. So that's
maybe we can vote actually on the panel. Who would use a 1.5? And who would use like 1.75 or larger?
1.5 to start is fine.
To start. Okay.
So I have one comment here. I see that you are holding the wire while you are going very slowly with the device. If you just press on the Dynaglide, you don't really need to hold the wire. Just go and you go.
In my experience, when you're starting with a 1.75 and the heavily calcified, it takes a lot of time to cross, and it's sometimes a real pain. You will get it through, but and sometimes you have to use. So tell us, what's your speed? Okay, we see it right now. Not much deceleration, 150 to 160 K RPM. So nice technique of a short contact with the plaque, with retrieval of the bird to let the coronary breathe. Slightly long run, but so far patient tolerates.
Hiram, did you give any nicardipine or verapamil or any sort of vasodilator before?
No, nothing. And it's just a Rotaglide solution here on the infusion.
You know, I've observed something over the years. You know, I don't put pacemakers and RCAs. I haven't been putting pacemakers for RCA rota for about 10 years. And what I find is that when you have skip beats and everything, it's time to stop, right? So you do a better rota job in the RCA because you don't burr as long. The no reflow cases you see are more often in the LED because you don't have that signal that comes to you. So I've been more and more like asking my techs and nurses to tell me, like when I'm hitting the 10-second, to just tell me you're at 10 now, to stop, because you don't have the same sort of warning side you will get from the RCA. I don't know what your experience, Catalin and Tony, what do you think about that?
Yeah, we started moving away from pacemakers as well and have some atropine ready. We still use vasodilators in the solution. That's how the stuff in the cath lab preps every time, some nitro and some verapamil. And I haven't seen, I think with the new technique of being gentle and paying attention to the RPMs and so forth, you're not getting that much no reflow nowadays. In fact, it's
right.
fairly
The
rare.
deceleration is key. I agree. I was a little too long here on the run, but we were not getting a lot of deceleration, so I kept going. Let's put the caravel.
So as you're planning to get your microcatheter down, any thoughts about giving some drugs in the way when you're gonna exchange your wire? Is it something that you do routinely? Is it something you would consider here?
I don't do routinely. There is a little bit ST change, so let's have adenosine on the table here. Any suggestion there?
Because I think it's a simple way to, when you're going and exchanging your wire, you just bring your microcatheter down, you pull your rotor wire, and at the same
give it through the microcatheter, you mean?
That's correct. Then you treat, and then you give your drug to the distal, where it actually might make a difference than giving it in the guide. So and then afterward, put your wire of choice. And here, more support will be probably a good strategy. In my
And one comment here. Actually, you know, the nice thing having if you had an 8 French, you can actually trap the burr, and you don't have to worry about fluoroing, so you save some fluoro time. Okay. But I mean, it works on 6 French as well. Great. So Hiram, what's your plan now? Are you going to image IVUS OCT, or are you going to balloon?
Absolutely. What do you think I'm going to use, Manos?
Just making sure. And actually, that's a critical point. How many people were going to stand directly this one now?
Nobody.
No. Okay, I think the message of stent regret has got through people's mind, which is good.
So we have the adenosine there.
You know, if had Shockwave IVL been available in your lab, would anybody of you gone through the whole cycle of rota, or you would have got the small balloon, get some place to get the Shockwave balloon, and just go with this? Who would have gone right away with Shockwave here, if it's available?
Having used it in the periphery, I would say it really only works great if you have concentric calcium, and we don't know that yet.
Correct. However, you know, with the many cases I've seen in Europe, I mean, I haven't seen a lot of failed cases with that. And
Stefan, it might not have crossed though. The challenge with this is crossing, and this calcium and the difficulty getting even a 1.5 balloon. Oh, yeah. The chances of crossing would have been fair.
You're absolutely right. I meant You go with a 2.0 balloon or 1.5. You make a little place for your IVL balloon, because I totally agree that this device will not be a standalone.
And one comment from the panel, maybe we can have the hemodynamics a little bit. People want to see the blood pressure and things like that. If there's a chance of showing that from the back in Cleveland, that would be great.
Also the hemus. You want to see the hemus?
Yeah, if it's a chance to the hemus a little bit, that would be awesome. Did you have any hypotension during the runs, or he stayed?
No, she was super stable. So very stable from the hemus EKG standpoint. And because we were not having a lot of deceleration, that's why we made a kind of a long run, but very stable, man.
And hypotension in the cath lab is something that you really want to treat. Hypertension, you don't want to treat that for sure. It's on your side when you work, especially when you're doing rota and everything. So it's usually a good sign.
Quick comment on the balloons. Initially, I've noticed the Takeru balloons are they have very low profile and much better than the other ones. What's your experience? Any other balloon that has?
In Canada, we're sort of stuck with the same kind of balloons we've had in the U.S. as well. So my experience is based on cases I've done in Europe and everything. But there's a truckload of new balloons and Terumo balloons, a smaller profile that they're much better than the current generation of the other companies. So I think crossing is an issue for sure, but afterward will be, can you expand that lesion reasonably with balloons? Because crossing is one thing, but here in order to deliver shock wave, I see a lot the UK colleagues and everything using Ryuin balloon or those very high, super low profile balloons, crossing and then delivering the IVL and then starting the IVL done.
And there's also the Sapphire Pro. I would say the key ones are now Sapphire Pro and Takeru is coming. These are the two balloons for this kind of lesions. Sapphire is 1.0, Takeru is I think 1.5, the smallest, but we've used the Sapphire, it works very well. The problem is it ruptures. So if you can go through and it ruptures, but then if you made a little more opening, then it can go a little more. But
I think it's important to have both. I find that sometimes one will work and then the other won't, and vice versa. They're both very helpful, these sort of situations.
Yeah, absolutely.
Yeah, and on the more traditional line, the Sprinter Legend is actually still a very good balloon for crossing this type of lesions. Very low entry profile, which is the key feature that you need.
And I think you could have done is put a guide extension, a guide liner, get something in, get you more support. That's the other way to cross through this. Going through the algorithm balloon uncrossable, that's another way to handle it.
Yeah, but here I think we were like it was in the presumed balloon uncrossable lesion that they never even dared to do it, and it was absolutely appropriate. I would have done the same exact strategy. So you're going with IVUS right now, OCT right now, right?
With the OCT.
Okay.
Is it delivering okay? It looks like you're making good progress there.
Yeah, so key here is to avoid the kink right on the catheter. So you pull back a little bit the wire, rail it down. So I think we are far enough here. For those who are not very familiar with the anatomy of the OCT catheter, you have a distal marker, then a very long nose that has no image, just the RX component. Then the second marker is the lens, and the most proximal one is 50 millimeters apart, and the pullback is still go another 25 millimeters. So here we're going to cover all the way to the guide. Now I think it would be interesting for them to see primarily the OCT screen. You guys can.
Absolutely. Can we switch to the OCT, please? Perfect.
Let's go 12.
Will you inject manually or use the power injector?
So our setup here is already with the assist device, which it's helpful. We don't need to. So I just increase a little bit the flow rate and the total volume there.
Can you tell us what's the setup you're doing usually on the assist?
Usually I set for 5 cc's and 12, but I don't necessarily inject all that. right? So
And in terms of
usually I end
pressure?
up injecting about 8 and 9, and pressure I keep at 600 psi.
Okay.
All right. So feel the guide. The most common mistake is that the guide is not well engaged. This one is okay, so we're gonna auto-calibrate the system there. Enable, we're gonna spin fast. Take a cine, inject, and start. So if image acquisition is adequate, there is no point to leave the catheter there. Catheter comes out as the system is loading the image so we can review.
Good teaching point. You don't have to leave the patient ischemic while you're doing the analysis.
Look at the monster calcium there, guys.
Oh, yeah.
So Hiram, you know, you're obviously the world's expert on this, and I think many people in the audience would love if you can walk us step by step how you analyze the OCT.
Yeah.
That's one of the most common things we hear, and you've done this forever.
And please show us the cuts by the rota.
Just a little up here so I can see the... Yeah, we're gonna go step by step here. So one thing that I recommend, as we did on this case, you see that up. So is to have the default OCT and to the left, so I can see the OCT. Yeah, thanks, Nick. Is to do the acquisition with the 75 millimeters, right? So you gain a very long segment and you end up utilizing less dye. So then what you have here, since we have time, I'm going to describe a little bit of everything on the OCT here. So you can change your field of view. At this point we are 7. I think it's quite good for the sizing here, but it can go up to 10. So even the left main, you see, it's totally within the image. Right, so it's not true that you cannot do left main. All this is calcium. Let me zoom in the calcium.
Now, Hiram, one of the common things...
Is the coming good for you guys there or not?
We can see it okay, but one of the questions here is, we typically think the calcium, you can see backwards because the light goes through the calcium. Here we cannot. So can you just expand on this a little bit?
Yes, thanks, Manos. So I did a little zoom in a typical calcium here. So everything you know on IVUS, think the opposite, right? As Manos was saying, it's going to appear as dark. You don't have the acoustic shadow, because near infrared goes through the calcium. And it's the first time that actually you can see the posterior border of the calcium here. So that's where it was mentioned before that the thickness of the calcium is the new metric on OCT, right? So both IVUS and OCT can comment equally well on the R of calcium, on this case like 270 here. But OCT very often can give you a better idea on the thickness of the calcium. So here are example of circumferential calcium, but if you look at this calcium here, I'm not afraid of it because it's a very thin calcium. Any balloon can crack this.
And what's the thickness, the cutoff, Hiram? How do you call it thick or thin? What's the cutoff you're using?
Yeah, so there is some data from Japan that the magic number is around 500, 650 microns. I'm going to measure here just to give you, and the truth is that we don't measure systematically, but you calibrate your eyes at some point, right? So if I measure this calcium here, I'm going to drop 1 point here and go all the way there. It's about that. It's about this calcium thickness is when you start getting concerned. To my eyes, this still looks like a thin calcium that at high pressure you could fracture if you have to stand here. But one thing that before continuing on the calcium and get to our lesion here is here, right? So that's a serious calcium there on this side. If you have this calcium 360, that's a situation that probably would regret us not being on 8 French and put a bigger bore here. But you see that this calcium at this level here is much thinner. I hope you can see the resolution.
And Hiram, is that a cut from the rotablator, what you saw in the previous frame? Is that just what the rotablator did to the wall of the vessel?
So the rotablator, I think the best is here, Manos, like on this frame. So what happens is that you see the wire there? You see the wire?
Yep. And you see the shadowing of the wire?
So this is exactly the size of the bore. You see?
Got it. Okay.
So the rotablator is going to follow the bias of the wire, right? And going through the plaque. So if we measure here, we should be close to the 1.5. I hope the system doesn't call me a liar here. Let's see.
Yeah, it's very nice.
Yeah, it's very, very close, right? I mean, that's the bore excavating here, right?
And Hiram, if it goes orbital, how would it look like if it goes orbital versus rotational?
So orbital is more random, right? I mean, the rotablator, and we can feel this mechanically, right? The rotablator, after 2 passes, there is no resistance anymore. It's going to always follow this path, and that's it. So the advantage of rotablator is that it's very predictable. You know exactly what you're going to get. The disadvantage of rotablator that you doing 10 passes is not going to make look better. You're just going to get more, no reflow. With orbital, if you sit here a very long time, there is a chance that with the same device, you start getting close to 175 or even more of what we would get with a rotablator, right? But it's random. So when you see with orbital, the interaction with calcium is much more random than create this channel that you get with rotablator.
Why you choose IVUS, OCT over IVUS? Is there any particular reason here, or in your lab you just use the OCT?
Yeah, no, it's just that we do OCT for almost all the case. And that's a common topic. Again, I think we just need to all cheers for the intravascular imaging, whatever it is. And you need to stick with what you feel more comfortable workflow-wise and interpretation, right? Both are exponentially better than your judgment on angio, right?
So Hiram, based on...
For calcium, again, I think there is an edge on OCT because it gives you the thickness as you were describing.
So based on your analysis, you're comfortable that the burr you've used was enough and that subsequent balloon should expand that lesion?
Yes, and we can even direct stent here now if you want.
Hiram, can you, I think most people are uncomfortable on this on the panel, but but I think, can you show us on the top panel how you choose the size of the stent, the length of the stent? I mean, that's the unique opportunity, right, to show how to select your sizing, balloon and stent.
Yes. So we talk a lot about calcium, but at the end of the day, what we do is lumen, right? So what you guys see here on the mid panel is the lumen profile, which is just a cartoon. It's not an anatomic view, right? So if I take this and I rotate this plan, sorry, let me grab this. It's not easy to do this. Okay. You see, I rotate the L mode below. That's what we are used to, right? But the lumen profile is stay unchanged, right? So the lumen profile, what it's doing is that every frame is automatically segmented and is giving you the mean diameter and area. So if I can come here, I can show you the lumen contour. See? This is not us drawing. Every single frame has its segmentation. Okay? See?
Yep.
And it's very, very accurate segmentation. So based on this value, the algorithm creates this lumen profile here. So the workflow would be, if we want to treat lumen, do you guys agree that the lumen will curve around here?
Yep.
Yep.
On the blue, right?
Yep.
So I can put this as my distal reference. Sorry, I was on the right. So I come here. This is our distal reference. I press distal. Then we're going to select our proximal reference. And you can track on the screen. I mean, you can do angiocore registration, or you can simply follow with your eyes the dot of the lens here. So as I go proximal, we are getting close to the origin of that diagonal. You're going to see the diagonal coming on the screen there. You see at 5 o'clock. And how far you guys want to stand proximally? Lumen-wise, we are back to a normal lumen around here, I would say. Or do you want to go even more proximal?
Well, I'd like to hear the panel. Personally, I would stay as short as possible because you never know if you may have issues in expanding more proximal into the calcium. But, you know, is anybody have a different opinion on that? Would like to cover more proximal than just proximal to the diagonal?
No, I think if we choose a long stent, we're going to end up having some issues with deployment of the stent proximally in the calcium. I would prefer to just be as short as possible.
Yeah, remember why we're doing this is for a renal transplant, so the less metal here is probably, you know, the better.
So Hiram.
How about around here? I mean, just past the, or just proximal to the diagonal?
Yeah, something like that makes sense to most of the panel.
So if we drop a point here, now we have our stent length that is about 16 millimeters, see? Obviously, I always scan a little bit back and forward to see if there is a favorable landing zone. On this case, it's all calcified. I mean, we're not going to find any very good landing zone, right? So if you want to go short, I think we are talking about 16, 18 millimeter stents.
Right.
Is
So
that okay?
Yeah.
What's going to be your size then? 377 is the mean, it looks like, and then 18?
Yeah, so this post-stenotic dilatation here, right, is ectatic there. On this case, that situation that our proximal landing is actually smaller, right? And it's giving us 289 in diameter. We systematically go at least a quarter size bigger with OCT. It's just based on lumen here. When I have a very good landing zone, I systematically go at least 0.5 bigger. But on this one, it's not a good landing zone. If we go too strong here on our initial selection, we're going to end up with a small edge dissection there. So I would be more inclined to go with a 3.0 and then post you with a 3.5.
Yeah. So you just wanted to know, like, are you planning to use a non-compliant balloon right away, or you'd like to use a semi-compliant to start? Because you've made your pass with the rota, the microcatheters, so for sure a non-compliant could be delivered.
Yeah, I think for sure the non-compliant can be delivered. This one probably would save one balloon then.
And Hiram, are you going to go with a 3.015 or something, a little shorter, and just see if it expands?
We can even go with a 3.5. That's going to be our post-dilatation, but a short 3.5.
Yep.
Perfect. And again, I think it's a great example of how, you know, CT can really help you, right? I mean, I must say, I would have chosen a different size. I mean, this is beautiful.
So would anybody consider an angioscope or a carrying balloon just to prevent slippage?
I would, yeah, it depends on the expansion of the balloon, right? If the balloon subsequently expands very nicely, you could ask yourself if the scoring balloon adds any incremental value, especially after rota. So I think the key will be to see if the balloon expands nicely at this point, and then afterward make an appropriate decision on how to escalate in vessel preparation if need be. So are you planning to protect that diagonal given the calcium and the potential dissection that can arise? So is this something that you would be considering?
I'm not planning, Stefan, unless if you have a strong opinion.
It's a CTO, right? So
Oh, it's a CTO, yeah. So it's if it cannot be more occluded than than it is right now. So don't worry.
Right.
Hiram, as a primarily IVUS operator, the one thing that I look for is an immediate feedback response. So I would pre-dilate like you're doing, then IVUS again to see that the calcium's cracked. But you're not going to do another OCT run, are you? You're just going to go with whatever the balloon behaves like?
No, as I said, I want a direct stent. You guys didn't let me direct stent, but okay.
Yeah, we were.
Are you happy with the expansion?
Yes.
I think it looks
looks
very
great.
good.
Looks great. Oops.
I think another thing to pay attention to is the pressures that the balloon expands, because if it's, if it requires 20 atmospheres to get rid of the waste, there may be some recoil there. If it requires 6 atmospheres, that's a really good sign that you're not going to have any problems with the stent. So.
You may also, in a balloon...
You know, when so I see your balloon was a bit stuck in the plaque. Sometimes what can be very helpful is just to reinflate a bit in the plaque and then redeflate. Sometimes it works.
That's right.
But you know, that's one situation where you might be very happy you were in 6 French rather than in 8 French right now, because that sucking in of the guide might have...
Deep diving of the catheter, right?
Yeah.
You know, another thing that would have helped here is a wiggle wire.
So it's always a trade-off, right? 6 French sometimes is more forgives more about those, those maneuvers of the guides and everything.
So we take a 3018 stent.
For the balloon inflation, I was saying it helps sometimes to go in 2 different views to make sure the balloon is not deployed only in one view and not in the other, especially if you see haziness inside it.
Any value of using stent boost, or once your stent is deployed, to sort of try to optimize stent expansion? Obviously, it doesn't tell you if it's opposed, but for the expansion, is it something that I'd like to hear the panel, is it something that you guys are using commonly in your practice to assess expansions of stents? There's not much enthusiasm.
I think the main focus on lesion prep. I'm saying the main focus is really lesion prep. If you're satisfied with your lesion prep, that's typically not necessary.
I think where stent boost helps in a situation like this where you have so much calcium is to know when you post-dilate to make sure you stay inside the stent, especially in the proximal part of the stent here where you don't want to go too aggressive and split the...
Yeah, especially when you get that amount of calcium proximal and distal, obviously the risk of edge dissection is increased, and I assume that they will do a final run to assess, and in any way will know better.
Yeah, that is interesting, Stefan, that these angiographic stent optimization techniques are getting better and better. And although I do most of my case, particularly calcified case with a final CT run, they did. I have a couple of cases that it saved me with by placing using stent boost to place my final posio. I realized that one segment of the stent was grossly underexpanded on stent boost.
And I think it's very useful also for stent recoil. Sometimes when you have issues of stent recoil, stent boost can actually see the hourglass appearance of your stent very nicely. And one strategy I employ very commonly in this situation, if you have good balloon expansion and you have stent recoil, that's the reason why I keep some of the bare metal stents on the shelf, is that you've already covered the lesion with a stent. It's got drugs into it, and sometimes what you need is a better backup frame, and those ultra stent that have closed cell can make a huge difference, especially on osteal lesions, RCA, left main, post-cabbage. So if you have stent recoil, you just go with another stent. This lesion has too much recoil. You need a better backbone. And the drug's already there, so it don't make any difference than a synergy, basically. You've got a luminal drug up there, but you just needed a bigger frame. So especially in good size vessel, I think it's something that we can do.
So the guide is diving in. Any thoughts on the panel? What do you do when the balloon is really stuck and doesn't come out?
We just push on the balloon. It brings the guide back and pull the guide all the way up in the aorta.
Yeah, so you're pointing to the common situation where you get stuck with your guide, and then, so what I tell the fellow first is get the guide out, right? but you know, you don't want to have a jump and everything comes out at the same time too. So it's a maneuver where you got to be careful. Also, I think at some point, sometimes you're just reinflating a bit the balloon and deflating sometimes can make a difference. Manos, what do you do usually in these situations?
Well, I think the key thing is patience. I mean, exactly what Hiram is doing. I mean, the thing you don't want to do is just yank it, and then the guy dives in, dissect, and now you have another situation. And that happens to all of us. I get a little impatient sometimes. Just take your time. I mean, if worse comes to worse, if it's really tough, then getting a guide extension is another option, a little safer than getting the whole guide in. As you said, having the 6 French here is actually advantageous because you can deep dive and it's a big vessel, it's less likely to cause. But this is not an uncommon problem. And any other thoughts, Timir? Or
another thing that you can do here is sometimes these balloons pancake, especially if you stay negative when you pull them out. So sometimes we release the pressure and leave them neutral to relieve that pancaking effect.
It's a good point, Kathleen. The neutral sometimes make the balloon much free than negative, right?
Yep. Just leave it neutral, then only negative can just gets the wings out a bit and then gets it out.
358.
You know, I have a question here. I know I would have chosen myself a small stent, and that's what I said, but would any of my colleagues be concerned that he rotated proximal to the calcium? So there's area in the artery where he has rotated and exposed some tissue, but is not stented. Is that any concern at all?
So I'm sorry because of the. So you said about the rota and miss.
He rotated more proximally,
Yeah,
so
yeah.
He worked on the artery proximally, but that's not covered with a stent. Would that be concern for
It's
future?
a very good question. What do you think? Do you think that, like, an anatomical mismatch of where you cover your stent versus where we rota may have an impact in the final result? Do we know, Manos?
One data that we know that is very interesting data is that the calcium per se is going to be the tissue with the least proliferation of a tissue. It's basically a dead tissue there, right? We have more restenosis on calcium just because your acute result is so poor in terms of, and then any tissue equals restenosis. But in a big lumen like this, ablating a little bit calcium, and I don't expect any significant tissue proliferation there.
I agree.
And I think, Hiram, you did OCT too, right? So you saw the lumen proximal. I didn't really see any major injuries, like any grooves on the wall there. So, I mean, but you're right. You still have some more superficial injury, but I would be less concerned here than in a smaller vessel.
It tends to be a very non-proliferative, to lack of a better word, tissue calcium.
So now you're going back with the NC balloon to post-dilate.
3.5, yeah.
Now, this is where you get the compression, longitudinal compression, if you push too hard. Any tips and tricks, Chadi, about how to prevent that longitudinal compression?
What's the question again, Manos?
So pushing the stent with the balloon with the stent, or the stent with the balloon, if it doesn't go, how do you avoid compressing the stent you just put in?
So add more negative on the balloon, either go more mega negative and advance it, or probably pull back the wire and advance it again, probably change the trajectory of the wire and advance slightly the balloon.
Oh yeah, beautiful, beautiful. Can you guys see there the stent optimization tool?
Yeah, very nice.
Yeah. And even here, I mean, we don't need OCT to tell us that segment, which was the calcified, is still underexpanded, right?
Yep. And you can, well, you can surely pot to even bigger than this 3.5 but you know it's always. So now you're going with the 3.5 right now?
Yeah, so we're gonna go up with the 3.5 at this level, so we're staying away from.
What's the balloon length?
From the edge. That's a 3.5 by 8. Keep going. Go 22.
So Manos was making that point of how do we manage balloons, pulse dilation balloon, when you want to get into a stent and you get this poor man's Ivis sign that your stent is underexpanded because your tip of your balloon is catching on the stent, so you know it's underexpanded. So the answer is never force. It's never force. You got to play with your guide, play with your wire, move it a bit, and then let your balloon go, but it's never forced, because if you push on it, all the stent platform can actually have longitudinal deformation, and then you can have issues. So as long as you remember that it's not forced, but it's more like playing with your wire. And one way to play with the wire, it's sometimes people forget about it, is if you pull your wire a bit and then knuckle it and push it downward, then the wire becomes sort of a bridge effect. You anchor it distal, and the more you're gonna push on the wire will induce a sinusoidal aspect of the wire. And then it will help you deflect the nose of your gear away from the side of the walls. So basically you're doing like sort of a wiggle-like effect. If you knuckle your wire, you push it downward, and then make it a little different, and then pull a bit and push on the wire. So therefore, the wire will go from one wall to the other wall of the artery while doing this, and then your balloon can get down. So it's a simple trick to overcome resistance beyond force. This is not force that's gonna help you. So,
and I think the other thing, Stefan, for a second, I think yesterday you mentioned it in the other live case, having the wiggle wire. The wiggle is making a comeback, and the best use is in this scenario where you have to go through a stand and you're hitting the stand. Having the wiggle can help you prevent hitting
totally
the other
agree.
stand.
Plus, the other thing is, this workflow included a microcatheter, which makes putting a wiggle wire in very simple. So I think it's a no-brainer to do it up front.
Once, whenever I'm ready for the fight and I've used the road, I don't recall a case that I've used ROTA that I've not exchanged for a wiggle afterward. Like, to me, is the go-to afterward, because I know it was a difficult case, and then getting stents in will be difficult, and if I can get the stent beyond, then I may have to put the stent more distal, and my wiggle will help me. So in many situations, I think the wiggle's such an old technology that's been so helpful, so we want to reawaken to the people who don't know about the technology.
And with some good wires going a little far down there, I don't know if you're going to pull it back a little bit.
So you should know that there's two wiggle version that's available. One that's fully radio opaque, and the one that's only radio opaque at the tip. The fully radio opaque is a bit annoying. It looks like you're working on a Miracle 12, whereas the non-radio opaque, so you got to order the right one, and then it looks like any workhorse wire. So you don't see as much the wire in your way, and doesn't impair your assessment of how you look at the lesion. So the wire would look exactly the same as we're looking here.
If you don't have a wiggle wire in your lab, you can turn a workhorse wire into a wiggle wire pretty easily with the needle introducer. You just put some gentle waves on the wire, on the core, and it's a wiggle.
Yep, there's one way to do it yourself. Make your own wiggle.
And one thing also for the audience, if you look at the radiation numbers, always good to look at those. On the very top is the air kerma, which is 0.8 something, 0.83. So we're still very low radiation dose. If you go further down, you'll see that he's working at 7.5 frames and low fluoro. So again, key for any case, especially complex cases, go low fluoro, low frames per second. Anyone in the panel using now 15 frames for fluoroscopy, or everyone is back to 7.5 or 6?
No, we changed routinely. All the lab is changed to low fluoro, 7.5. After the CTO work, this is the default, and nobody has complained. Nobody increases it to 15.
Yeah, one way to protect our brains and our radiation exposure is to protect our patients first. So, and it's not only for CTOs, it's for everyday angioplasty and everyday, there's no reason to administer more radiation nowadays with those beautiful imaging system we have. And I think we have a great example today that, in terms of imaging, in terms of everything, now it's pretty modern, and we don't have to use 15 frames per second. So you've done your pulse dilation. Are you planning to go with the OCT right now?
Yeah, so OCT, hopefully our final picture. Gonna always, before imaging, Janus on the nitro.
Are you right now doing another shot beyond your final shot with the OCT in, or?
No, that's it. I mean, for her, it wouldn't be that relevant as a dialysis patient, but we tend to have our final picture with the OCT inside, unless if catheter is creating kind of accordion or something that make our interpretation somehow compromised.
Yeah.
But if you look at OCT, everything is good, there is no point to downgrade yourself back to angio, right? And now you're seeing some haziness and making bad interpretation.
Yeah, if you trust your intercoronary imaging, then you trust it, and this angiogram should be enough for a final angiogram. I think it's very reasonable. The only issue is that you still have some supportive gear into the coronary, and for distal and proximal, then there might be an issue that may arise. I still like wire out shut. Personally, I may be an old dinosaur on this, but I've seen issues when pulling wires and small perforation and stuff. So I think it's still a good practice.
You know, one thing, although even though dialysis patients, sometimes they still have a little renal function. So I guess, you know, you want to minimize still the contrast as much as you can. But I agree with Hiram. I mean, if you can do it well and you have the expertise like he does for imaging, that's another great example of getting the information. Now, Hiram, do you ever do dextran for imaging without giving contrast in people with kidney issues?
Manos, we tried this in the past. I mean, the system now is so fast and efficient in terms of, I would claim that overall we can save dye, right, compared to non-OCT, because you minimize your angiographic projections. But if you go more on the mode of a zero dye, it's probably something that we should revisit together. I mean, put a group of people doing more of this, as we eventually do with IVUS, right? Would be the OCT version of it.
I'm just looking at something right now. I just want to like bring people. The heart rate is 102, 103. Sometimes the pressure is a bit high. Sometimes it's a sign that the patient needs to void or something else because they're uncomfortable. But one thing you can do, especially if you're in the RCA and you think that this tachycardia is a bit annoying, just give beta blockers when the patient is stable. It's something that we have lots of room in terms of pressure and everything. So when you think that the heart rate is a bit annoying to you, if you have room for pressure, I think it's very useful. Learn it from Chris Buller, pretty old trick from Old Monkey. That still works a lot.
So back to the OCT, guys, please, on the screen. We have the OCT on the screen. So OCT is live there. You see that there is blood on the catheter, so we're going to purge the side port. Now it's clean. You don't see stent, so we are distal enough, right? So that's a good position to start our pullback. Are we running out of dye there, guys? Give us just a second, because the assist is great when it works, but it's giving a little bit of...
And Hiram, so you use assist for your injections. Do you ever you don't do manual injections for OCT? I guess assist helps much more, right?
Do what? Sorry, Manos?
Do you ever do manual injection? Like, for example, some labs, we don't have assist in our lab. We only have manual injection. In this case, do you get like the 20 cc, the thin syringes to get it done? What do you recommend if you don't have the assist in your lab?
So paradoxically, when we are manual, what I recommend is actually to stay with the 8 cc syringe, because most of the time your suboptimal image is lack of a flow rate. Right, so you have more power with a small syringe than you do with the big syringe. Rarely is because you need more volume, it's more the flow rate. So the compromise is that you might not have the 2 seconds of pullback, right? And your 75 is going to be cut to 50, something like that. But bottom line, I would say manual, manifold, just stick with the 8 cc syringe. I think they tend to be better imaged.
Okay, I see the heart rate is coming down.
We calibrate, enable. I'm going to take a cine, inject, and pull back. So our distal edge is right at that ectatic area. This is the new software that talks about tapering. It's interesting. Do we have another 5 minutes or so?
Yeah, you still have like 13 minutes right now, so for live transmission. So I think with the stand rendering feature and unopposed struts, could you walk us through this to make us understand a bit better where you will have to work?
First thing, I'm going to change a little bit this field of view so we make things better here to visualization, right? So pulse OCT, we look at the edge for dissection. You see that we actually malapose here against calcium, right? I'm not chasing this. That's exactly what I want to be, because if I balloon here, I'm going to dissect this calcium. So that's great. This malaposition here, you see, labeled as red dots, is lack of conformability because the calcium is protruding here, so we are not conforming to this contour. Same here. Now we are posed here. We probably hit all this segment with the 3.5. This is a nice example of calcium fracture that Jay mentioned before. Look at that. See the separation of the calcium here? So that's how you gain lumen on calcium. We cannot compress calcium, but we fracture the calcium. Right? That's our diagonal coming there. And the septal on the opposite side, so septal diagonal. Another example of a calcium fracture here at the bottom. And here is interesting, the interpretation. You see that the soft is labeled in this segment in red, because it's tell me that it's underexpanded. So just based on the size of the volume, but it's looking to a reference that is ectatic. So it's difficult for me to interpret. If I change my reference to here, now I'm well expanded. Does it make sense?
Yep.
So you are okay expanded depending on your reference, right? I mean, if I choose this as my reference, which is that ectatic segment, we are grossly underexpanded on this region.
Do you think by using a semi-compliant balloon, 3.5, maybe lower pressure, that you could overcome some of these struts by allowing the balloon to conform a bit better and then get better a position than only going bigger? Because for sure the proximal you'll need to get bigger, but what about in the mid segment when you have like few struts that are not opposed? What's going to be your strategy?
No, so they really don't bother me, Stefan. I mean, I think these struts, it's just that the calcium is so irregular. You see all these fractures and cavity that we create. Then the softer pick these struts, and it's a lack of conformability, right?
Okay.
So
there's no way to overcome?
For malaposition is that if there is a gross mismatch, meaning we choose a stent that is too small for that vessel, we probably should react. If it's lack of conformability, like random struts because of the presence of calcium, I never react. So my whole focus here is on the size of the lumen, right? And I question if this segment here deserves a little bit more pressure. We went with the 3.5 at 24 ATMs. I mean, we could again come in here, but then the other interpretation is that you see calcium is in one side, and the other side is normal vessel. So we're just going to be stretching a normal vessel. I don't think it's worth it.
Hiram, can you walk us a little bit? I know we all think that acute malposition doesn't really lead to adverse outcomes unless something very pronounced. What's your cutoff and how you decide? Here you said it doesn't look very impressive. How do you think about it? When is it big enough that you want to post-dilate more aggressively, and when is it not, that you are okay the way it is?
Right. I think my category, Manos, is more going to rephrase. Like, let's say if we were to land this stent here, distal, okay? You still see the OCT there, right?
Yep.
If this stent was landed here on this ectatic segment, right? If we were to land here, it's a 3.0 stent landing the 4.1 vessel, right?
Yep.
This is a 360 malposition because of a mismatching size, right? On that situation, I would put a 4.0 semi-compliant nominal pressure, and it's going to easily oppose this stent,
Yep.
right? When we get to the calcium, it's not a mismatch anymore. It's just the random interaction of the struts and this protruding fracture calcium and everything. Like, why would I chase these struts here, and there is no way to oppose these struts there, right?
Okay.
I mean, it's a cavity that we just create. So I tend to stay away from the magic numbers for malposition because I think what the literature shows us is that, yes, there are thresholds that if you repeat OCT a few months down the road, they tend to heal completely. So the closer the strut is from the wall, the easiest for tissue to proliferate and resolve this malposition. But that's about it.
Hiram, what about the proximal?
Resolving this, we're going to impact outcome. But in the LAD, if I have 360 malapose stent, in my mind, what is passing is that, oh, if this lady ever need a reintervention, I don't want to go behind this stent, so then I want to fix.
And then, Hiram, would you mind showing us the distal edge again? Now,
Yeah.
is there, I mean, there is no, but how do you tell a dissection? There's the blood artifact. How can you just make sure there's no dissection, although there may be some artifact there, and usually the visualization is not as good there? Any thoughts here and in general?
Yeah, so the dissection usually, I gotta turn off the stent rendering here so you can better appreciate the image there. The dissection, I mean, probably the main criticism, Manos, and you have worked on this on OCT, is that we tend to overreact eventually to things, right? So on this, I cannot see any flap of dissection, right? And then if I see a flap of dissection, do I need to react to it? That's the main criticism. And it's interesting that many years ago with Julio, he was doing this first trials with IVUS and OCT side by side. And angiographically was okay, IVUS was okay, and you had a little flap on OCT. When I look at this flap, I say, well, he didn't do anything, but he was right because when he brings the patient back, they virtually all heal. But there is a 5% chance of a restenosis on the edge dissection, particularly if it's against lipid. So plan A is avoid edge dissection, and I think that's why I tend to be conservative on my initial stent diameter and then aggressive on the post-deal, staying away from the edges.
Hiram, we have 5 minutes. We still have 5 minutes with you. Can you for the room show us the simultaneous recording of your angiogram you did at the same time, just to make a bit of a correlation? We have the image on the OCT, but it's a bit like blur on this. If you could just go on your reading on your angiogram.
On the point on the angio where we are. Let me do something better here. Let me do. We good on the ACT there, guys? Let me do call registration here. I cannot see the. Yeah, I can see it. So these are the steps for formal angio-correg on OCT. That's an interesting feature. So what you do is basically creating a center line on the vessel. And the software should be able to detect the lens and track this digitally, because the problem here is that if I just track this visually, my frame rate is 7 on angio and is much higher on OCT, right? So there is a discrepancy there. So if I accept this, now on angio, can you see better there on angio now?
Yep. But you know, just angiographically, you see, we see.
You see the white marker there?
Yep.
That's where we are. So if, and it's interesting that you can place your blue bars also on the screen, see? Where they start and end. And you can color code areas of a potential under expansion, but I mentioned that the issue here is to define your distal reference, right? So if we define the ectatic area, we are grossly underexpanded. If we
And
can
Hiram, according to what you're saying, the waste that we can still see in the stent is not something that you would like to overcome based on the information you got by OCT, because you fear that the expansion would go against the calcium and you might not get any better result. Is that what you interpreted at the end?
Yeah, so if I look at here, right, you see that this lumen profile, there is a little bit of waste on this segment here.
Yep.
On the OCT, you can see my cursor there. So then I go to the cross-section view, what's going on here. And what's going on here is that in one side I have calcium, and the other side I have a normal vessel. So
Hiram,
I know that on eccentric calcium, the only thing that I'm going to be doing is stretching this normal vessel more and more, which I don't think that there is a role for it. Paradoxically, I think we tend to do more if we are dealing with concentric calcium. Then we keep trying to make that lumen bigger.
Hiram, we're at the end of this session. Thank you very much for a beautiful case highlighting very modern techniques of lesion preparation in the calcified, long calcified LAD. You showed the beautiful tips and tricks on how to cross those lesions, how to manage the lesion, how to well prepare the lesion, how to image it, guide your stent expansion, and do a proper job that will likely benefit on the long term. So on behalf of the CVI organization and all the panel here with me, we congratulate you for a beautiful demonstration and look forward to see you in a future event.
Enjoy Denver. Thank you for